I think this raises the other question: is do we need to keep people on BTK inhibitors indefinitely? I mean, if someone's in a great remission, unfortunately, it's rarely a complete remission, at least not as single agent, but at a great remission, can we take them off? We know sort of anecdotally that there are patients that that you take them off for an adverse event, and they do fine for a few years. But that said, I personally have been reluctant to stop BTK inhibition in someone who's tolerating the treatment well, because we know that there's still disease there. They're not getting into MRD negative, or at least very rarely, and not even into complete remission, and it's just a matter of time. Maybe I'm too conservative. What's your approach?
Yeah, I think I share this view in a way, but I think we are also lacking data, because we're currently using ibrutinib like we use the kinase inhibitors for treating CML, even though the disease kinetics are quite different. And I think you could make the point to say, well, you could also treat to best response with a BTK inhibitor, and then stop treatment in a patient who's low risk and who has disease kinetics where maybe it took the patient several years to need treatment. So if you have a patient who's low risk, long lymphocyte doubling time, and maybe needing several years until such a patient needs treatment, if you treat that patient 1 or 2 years with a BTK inhibitor with or without CD20 antibody, I think those patients could be in a relatively good remission, which obviously wouldn't be a MRD negative remission, but I would imagine those patients could have quite a durable remission and could have a treatment-free interval of several years. We are doing clinical trials now to ask that question, if that's an alternative to long-term kinase inhibitor therapy, because truly that's the unsolved problem. The BTK inhibitors are great drugs, but many patients eventually drop off because of more or less problematic side effects. But in reality, many patients over the years do not like to be on treatment or have side effects, so they have to come off. So I think there's a good rationale to look a little deeper into whether or not there's maybe rationale to, in certain selected patients, to go for shorter exposure and maybe treating them for a certain period of time and then taking them off and treating them again. So we're going to try to look into that. I think single agent BTK inhibitor therapy really takes a long time to get patients into something that's close to a CR. So what we are doing with clinical trials now is to combine it with a CD20 antibody, expose patients to approximately for 2 years. With that, I think many patients, maybe half of the patients, may be in a complete remission. And then we're going to take them off and see how that goes. Are you pursuing anything similar to that?
No, I mean, most of our efforts have been along some of these other combination studies, time-limited therapy based on combinations with venetoclax, and trying to get people off trial, or off drug, I should say, based on getting them to a really deep remission. But I'm interested to learn about your study and and how that does. I suspect you're using a low-risk patient population. Is that right? So people with low-risk cytogenetics and that kind of thing.
Yes, that's true. 17 deleted patients, for example, wouldn't qualify for that study. Otherwise, we kept it pretty open, but we have an alternative frontline study, which is a venetoclax BTK inhibitor combination study with obinutuzumab. So we want to kind of prioritize that other one for higher risk patients, this one for lower risk patients. And what I anticipate that maybe lymphocyte doubling time is going to come in as something that we always use also to assess our patients. Somebody has a very low lymphocyte doubling time. I think then these time-limited approaches with BTK inhibitors could become an alternative to this very long-term treatment with the BTK inhibitors. But yeah, we are just opening these studies, so I can't really tell you about any experience, and all these trials are going to take us quite a long time to really have a reasonable readout. So I don't expect to have any data for another 2 or 3 years because we're just starting. Patients are going to be treated for 2 years and then come off, and then it's going to take us a while to generate all this data.